So with that, I'd like to introduce Ellen Eaton. Ellen Eaton is going to talk about a topic which I think all of you are probably dealing with. She calls her talk "A Pound of Cure: Exploring the Potential Glucagon-Like Peptide Receptors and Other Substance for Substance Use Treatments, including opioids and other issues." Ellen is at the University of Alabama. She heads their program that focuses on substance use disorder. She works in the 1917 clinic that Mike Sagg started. She has a lot of experience in this area and is clearly one of the national leaders, very active at IAS-USA initiatives in this area. So we're very pleased to have Ellen with us. Ellen?
Great. Thank you so much for the introduction. Before I get started, I want to make sure that you all can see the slide presentation mode and hear me okay.
Yep, we can see that.
Great. Okay. All right. Well, thank you so much. Catchy title. I do want to make sure that we save the best for last. So before we start talking about these new exciting GLP-1 receptor agonists, I will review with you updates on substance use treatment broadly with an emphasis on non-opioid use disorders. Right. Financial relationships here. And our learning objectives. After attending this presentation today, I hope that you will be able to summarize substance use trends in people with HIV, list evidence-based pharmacotherapy for common substance use disorders, identify glucagon-like peptide-1 receptor agonists, GLP-1 RAs, as I will refer to them going forward, as a promising treatment for substance use disorder, but still with many questions unanswered. So I'll start by giving you some substance use trends here in my part of the country in Alabama, and then we'll talk about national trends. This is some work that I've done here over the last 4 years, looking at Ryan White funded HIV clinics in Alabama. And you can see stars here on the map representing large clinics with smaller stars representing satellite clinics. In this research, we generated over 4,000 patient-reported outcomes using validated surveys, such as the Audit-C for alcohol use disorder and the ASSIST for substance use disorder. We captured a group that was mostly male and Black with a median age of 47, which is representative of our HIV epidemic here in the Deep South. We found that moderate to severe alcohol use was actually really high, 22% reporting moderate to severe alcohol risk. And the variation geographically was significant. So some clinics had about 14%, others had closer to 28%. When we asked patients about substance use as part of their routine clinical care, again, with these patient-reported outcomes that they would complete on a tablet at the point of clinical care, much like you all may check into your clinic and complete on an iPad some health history and symptoms, our patients were given the tablet and asked about the validated substance use tool called the ASSIST or for substance use. And what they reported was about 30% reporting substance use broadly, with most of that being cannabis, 24%. And you can see a broad clinic variation here. There are also about 9% reporting stimulants, so that would be mostly methamphetamines in our part of the country, but also cocaine. 3% reporting inhalants, which was interesting to me. I was not expecting that. Opioids not as high, 2% reporting opioids. We do know that those who are reporting opioids often have pretty significant opioid use disorder that does affect a lot of their health outcomes. So a small but sick group in our experience here in Alabama. And then sedatives and hallucinogens, about 1%. As you probably expect, we have a lot of comorbid mood disorders. So when this group was asked about depressive symptoms and anxiety, we found a lot of symptoms. Specifically the PHQ-9 for depression, we found that 12% had moderate to severe depression based on these screenings. And again, that ranged from 11 to 42%. So in some of our clinics, 42% of individuals responded that they had symptoms consistent with moderate to severe depression, which is pretty significant. And then lastly, I did add a little plug. We did ask at the end of these surveys if individuals were interested in participating in future research, paid research. Almost half said yes, and I just wanted to put that there as a reminder that these individuals are often not represented in the clinical trials that you may read, the JAMA, the evidence-based best practice that you are providing to your patients. Many of these patients in the Deep South are not included in that study. And so this gave us hope and encouragement that we can start to recruit more from these rural and underserved communities. So those are our trends here in Alabama. Looking at national samples, you may be familiar with the CNICS cohort, CFAR Network of Integrated Clinical Systems. They have published on their substance use trends. Specifically, this paper is on people with HIV who are new to care, 2010 to 2019. This cohort was mostly male and middle-aged again, more non-Hispanic white and Hispanic participants than in the Alabama data I just shared with you. And what you'll see here of this group who is new to care, alcohol use is very high at 78%. So I went back and read this paper a couple times to make sure I was understanding this correctly. That is very high. They are having a new diagnosis. This may be a situational increase in their alcohol use, but very notable. Cannabis use was similar to what we see in Alabama, about 36%. Stimulant use, you can see 8% reporting cocaine, 12% methamphetamines, opioids 3%, again, similar to what we found in Alabama, and then also reporting a significant burden of comorbid mental health conditions, depression or anxiety here, about 36%. And I just have an image of the geographic distribution of the CNICS cohort, so you can see this is a pretty broad representation nationally that is contributing to this data here. One more study, this is a CFAR Network of Integrated Clinical Systems cohort from 2017 to 2021, so a little bit more contemporary than the one I last showed you. This is participants broadly. The last slide was those that are new to care. This is broadly people with HIV. And what you can see here is that cigarettes, specifically combustible cigarette use, is 26%. This is a reduction from past, but interestingly, we are seeing e-cigarettes, vaporized nicotine, ever use of these e-cigarettes, participants are reporting about 11% reporting ever using, and then you can see some are using a small number reporting use a few times a month, a few times a week. I was surprised by this data because I'm seeing a lot of e-cigarettes and vaping in my clinic. I do see a biased population because they do mostly have substance use disorders, and we know that substance use disorders often go together: stimulants and cigarette use, opioids and cigarette use, mental illness and e-cigarette use. So I was surprised by this data, a little lower than what I see, but certainly a broader sample here nationally. And just a reminder that the combustible cigarettes, so what you think about traditionally with cigarettes, has gone down, and that's a good thing for our patients. Okay, moving to stimulant use trends. I did highlight these outcomes because this is what I'm seeing in my population, that it's contributing to a lot of morbidity and mortality. And I imagine many of you are also seeing this in your clinics. Drug overdose deaths involving stimulants are really on the rise, from about 12,000 in 2015 to 53,000 in 2021. The overdose death rates are up 3 times for cocaine, 12 times higher for other stimulants, specifically meth. And this is thought to be due to the combination of stimulants with opioids. And these combinations can be particularly deadly. I have seen that in a lot of our data here. A lot of the decedent data, the coroner data that we've seen, is showing the combination of opioids with cocaine, opioids with meth. A lot of the opioids is fentanyl in those combinations. In addition to overdose, we do see cardiac, psychiatric, and infectious comorbidities. So just important to remember, a lot of us here are in the practice of HIV prevention and treatment, but remember that we also see hepatitis C. We're seeing a resurgence of hepatitis B, even in places like Alabama, where we traditionally didn't have a lot of hepatitis B. Obviously, you know about hepatitis A in people who are living unhoused and sharing substances together. And then a whole host of sexually transmitted infections, bloodstream infections for people who inject drugs. So just remember that it is not just the overdose risk, but there's a whole host of comorbid conditions we see as well. So the most prevalent substance use, in summarizing those slides, in this order, is what we are seeing both in the Deep South and nationally. Alcohol, very common. Cannabis, tobacco, stimulants, and then opioids. For the purpose of today's talk, we're really going to focus on alcohol, tobacco, and stimulants because we've done a lot of content with IAS-USA specifically around opioids. Those are available on demand, but we're going to focus on these other threats to our patient populations. Cannabis, I did not focus a lot on. We know that that is an evolving landscape. It is not available for medical use in the state of Alabama, but many of you are practicing in places where it is available and is being used for therapeutic purposes. So it's really hard to tease out right now what is therapeutic use, what is recreational use, what is a use disorder. So we're just going to leave that one alone for now. A lot of moving parts there. So let's go back to the learning objectives. We've summarized these substance use trends in people living with HIV. And now we're going to go through evidence-based pharmacotherapy for these common substance use disorders. And then lastly, we're going to talk about this new drug class, the GLP-1 receptor agonist, as a promising treatment for substance use disorder. So before we talk about treatment, I did want to remind you that we should all be screening our patients as part of routine care. Our patients should receive screening for substance use at all healthcare encounters, whether that involves a tablet, as I mentioned we do here in Alabama, or a paper or a verbal screening where you as the clinician or your team uses a validated tool to ask about alcohol use, substance use. And then it's also important to inquire about the methods of use, whether that's injection, pills, insufflation, which is just a fancy way of saying snorted. We do know based on CDC data that a lot of people who previously injected opioids are moving to insufflation or snorting as a form of harm reduction. That is a national trend. A lot of our patients who previously injected are seeing friends, contacts, family members die of injection of fentanyl, and they have therefore moved to what we know is safer harm reduction. They're snorting it, and as a means to stay alive, survive, and not overdose. And then lastly, a reminder that we should also be screening for depression at least annually in our patient population. As you saw in our national and regional data on substance use trend, there's a ton of depression and anxiety that goes hand in hand with these substance use disorders. So really treating the substance use disorder also requires that we get to the underlying comorbidities, whether it's depression or trauma, et cetera, and provide some interventions there. And you can see the primary care guidance and ART guidelines here for additional information. Alcohol use disorder. So not super new, innovative, or exciting, but as you saw from these slides, a lot of our patients are drinking a lot. I love this slide. It is found on Medscape. It is a very easy tool for clinicians like me who are infectious disease doctors and maybe didn't get a ton of training as part of our residency and fellowship on alcohol use disorders, but really important to screen, provide a brief intervention, and refer to treatment. And that is referred to as SBIRT, screening, brief intervention, referral to treatment. Across the top, you can see a general benchmarking of how much alcohol a woman could drink and be considered low risk, moving to higher, 4 drinks a day, for example, for a woman or a man. And you can see the respective recommendation. In addition, you can see that if they have concerning behaviors, you can see around the middle rectangle, administer the audit screening. That is a validated tool for alcohol use disorder. So after you as a clinician inquire or have clinical suspicions, it is recommended that you provide a validated alcohol screening tool. You see the audit example or the DASC screening. And when you get a score based on their responses to that, it is important that you make additional recommendations based on what you're seeing here. If they are low risk, you may, and this is at the very bottom rectangle, if they're low risk based on those results, you may just want to congratulate them. Those are healthy behaviors, and continue to monitor. As you move across to the right, that bottom rectangle, as you're seeing higher risk based on higher scores, you're going to want to recommend through motivational interviewing, for example, that they lower their risk, that they reduce to lower levels. That may be a glass of wine or 1 alcoholic beverage a day for a woman, 2 for a man, but always that harm reduction. We don't have to start by quitting cold turkey, but how can we reduce our use to get into a safer range? As you move across, you're going to see that some patients may need to be referred to treatment. They may need to be referred to an addiction medicine specialist. If this is not something that you're comfortable managing, they may need to be referred to an ER if they are having acute withdrawal, for example, from alcohol. And as with all of our patients, they may not be interested in discussing this with you the first time. This should be done every visit as it's recommended. We screen every visit. And I've had a lot of patients who, over time, getting to know me, developing a therapeutic rapport and relationship, at that fifth visit, they're willing to talk about it. They're willing to talk to a counselor. They're interested in starting maybe pharmacotherapy or some other intervention for alcohol use disorder. So just a reminder, and the literature does show that what you're doing matters. Patients, although it may not seem like they're listening to you and taking your advice, there's good literature that when we counsel our patients on substance use disorder, whether it's tobacco or alcohol, that is actually one of the most powerful tools in terms of recovery, is hearing from a trusted provider that this is affecting your health, and encouraging them to take action is actually a powerful tool. I know it gets hard when we feel like we're a broken record to the same patients over and over, but we are a powerful tool. So don't forget the value of discussing this. Okay, so let's go through some pharmacotherapy. Here's a list. This is a great table from Up to Date. I often use this with my trainees or myself when I need to remind myself what are our options for this patient. You can see along the left, we have naltrexone, intramuscular and oral, acamprosate, disulfiram, and then topiramate, which has the least amount of data. You can see that all of these, with the exception of the top intramuscular naltrexone, are oral, and some of them involve multiple daily dosing. For that reason, a lot of us look to naltrexone. It is an IM every 4 weeks, which can be easier for some patients to adhere to. The acamprosate, 3 times a day is just really hard for some patients, as are medications where you have to start with a loading dose and increase. I've just had less success with people wanting to take that on. I will note that the naltrexone intramuscular does have some challenges in terms of insurance. If you live in a Medicaid non-expansion state like myself, you may have to refer people to a pharmacy who can provide the injection across town at the pharmacy. So, a lot of additional details that you may need to work out as you're thinking about providing this to your patients, but can provide a lot of benefits. And if you can't get access to intramuscular, try the oral naltrexone. I have found it intimidating to think about treating addiction in my practice, but as I've added slowly to my buffet of services for people with substance use disorder, it gets easier. Start one patient on naltrexone. Okay, you feel comfortable, add another. None of these are brand new meds that are emerging with a lack of evidence. These are all tried and true evidence-based interventions that we as internists can provide. Okay, moving on to tobacco use disorder. Also not super new, not an emerging threat, but arguably one of the most morbid substance use disorders in our patient population. As you remember from the prior slide, combustible cigarettes are decreasing, vaping and e-cigarettes on the rise. We're still figuring out what that change means for our patients. Is it truly safer? But in the meantime, I would encourage you to focus on those who are using those combustible cigarettes, good old-fashioned cigarettes, and think about this evidence-based approach. This is from FDA.gov. I love it because it is the ask, advise, assist kind of model. So as I mentioned previously with alcohol use, there's great data that us asking and advising is a powerful tool. Forget about all the fancy pharmacotherapy. Just the fact that you ask this visit and next visit and the next visit, develop a rapport, and in a therapeutic, not a judgy or stigmatizing way, start chipping away at this behavior, you can make a difference. And I think that's really important for our clinicians to remember, that we are a powerful tool. So ask about tobacco use, ask about their history and pattern, counsel them on the risk. What I tell my patients is that their risk of dying from HIV with these ART meds is super low. They are much more likely to die of a tobacco-related cancer or comorbidity, heart disease, stroke, etc., than they are of HIV. And I use that to frame the discussion, and we start talking about the cost of cigarettes these days and how it's so much harder to play pickup basketball. And we chip away at the things that our patients can do once they get rid of the cigarettes. And so just a reminder, ask, advise, and then offer therapy. I think I have another box here. This is our first line FDA approved is the varenicline, which is a well-known oral medication or the combination of nicotine replacement products. So that could be a patch plus a lozenge, patch plus a gum. There's even nasal sprays or inhalers for those who have good insurance. And at the top here, you'll see offer both pharmacotherapy and behavioral treatment for all patients, even those who are not ready to quit. I also write down the 1-800-QUIT-NOW, which is a free hotline on a sticky note, and I hand it to them. A lot of patients are resistant, and I just challenge them to call that number once. I'll see you back in 6 months. Tell me how it went. They may not be ready to quit. I just encourage them to explore that. You can see some other second line pharmacotherapy, and you can see a combination of bupropion, varenicline. You can see all these different combinations. This is the protocol. I will say, in my experience, I start by asking, have you ever quit before, and how did you do it? And patients who have had a great experience with one of these are going to be more likely to try it. In my experience, you have buy-in. It worked 5 years ago. Patients who've had a bad experience, for example, with the patches or varenicline, it's harder for me to get them to try it again. Didn't work last time, not interested. But tobacco use disorder is one of those conditions where we have several approved pharmacotherapies. So that is great news to have options. Options are always good. Okay. All right. Just advancing here. Sorry, guys. There we go. Okay. Stimulant use disorder. I gave you a lot of data on the prevalence and the adverse outcomes with stimulant use disorder. I do want to remind you that stimulants are cocaine, crack cocaine, which we see smoked, we see cocaine injected, we see it insufflated, which is snorted. We see methamphetamine use, another stimulant. That is the stimulant I am seeing the most in my community. Amphetamines can be, I have patients who smoke them, who snort them, who inject them. I have patients who wad it up in toilet paper and swallow it. I have patients who rub it on their gums first thing in the morning. Some patients use it rectally. So a whole host of use behaviors with stimulants. Contingency management is a standard of care. And this is one of the most challenging things about stimulant use disorders. They can be very challenging to treat. We do not have great pharmacotherapy. Unlike opioid use disorder, where we have methadone and buprenorphine, we do not have an equivalent highly effective treatment for stimulant use disorder. So contingency management is really the standard of care. Contingency management involves giving some sort of incentive to people when they have a period of recovery where they're not using. So what that may look like, they came in to your clinic, they've reported, ongoing meth use, and you encourage them to come back and see you in a few weeks. And if their urine drug screen has no evidence of methamphetamines and they report recovery for that 2-week period, maybe they are able to put their hand in a fishbowl in your clinic and pull out an inspirational quote or a $5 gift card to McDonald's or $20 cash, whatever that looks like. Contingency management has been shown to help people get into recovery and stay in recovery from stimulant use disorder in a much more effective way than the pharmacotherapies that I'm going to tell you about here in a minute. This contingency management can be combined with other interventions or behavioral therapies like cognitive behavioral therapy. One thing I do just want to speak to is that ADHD, depression, anxiety, and eating disorders are very common with stimulant use disorder. I have a lot of patients with ADHD diagnoses who maybe have been on and off pharmacotherapy, specifically stimulants for ADHD, started using meth recreationally. Now they can't get a provider who will prescribe their ADHD meds because they consistently have meth in their system. Similarly, a lot of patients with anxiety. I have fewer patients with eating disorder, but we have seen that it is very common in the literature. So talk to your patients with stimulant use disorder about ADHD. Remind them that there are very effective treatments for ADHD, but they are really going to need to get in recovery from their meth use. I know very few providers who feel comfortable treating ADHD with stimulants while someone is getting non-medical stimulants, such as meth. And if they are self-medicating with their stimulants, I remind them there are much safer stimulants that your provider can prescribe than what you're getting on the street. We know a lot of the stimulants in Alabama and nationally are contaminated with anything from fentanyl, which is highly fatal, to things like xylazine, which is a veterinary sedative that can cause a lot of sedation, overdose, wounds, etc. So that is something to be aware of. Talk to your patients about ADHD, and if they are self-medicating, please encourage them to get FDA-approved treatment for ADHD rather than self-medicating with these unmonitored stimulants that they can get on the street, for example. Pharmacotherapy. So I mentioned there are some pharmacotherapies that can be utilized off-label for stimulant use disorder. I am giving you the ASAM, American Society of Addiction Medicine guidelines below, in addition to our IAS-USA guidance, where we talk about this as well. There is now a push to consider these psychostimulants if you're an addiction medicine provider. And then for those of us who are not, like myself, there is a push for us to consider things like bupropion, mirtazapine, topiramate, and naltrexone for stimulant use disorder. Modestly effective. There's some data that bupropion combined with naltrexone for stimulant use disorder can reduce stimulant use. I think the number needed to treat is about 9. So this is an emerging combination. The bupropion and naltrexone has not yet made it to our guidance yet. You will hear more about that, but there is a push to try some of these pharmacotherapies because really we just don't have much else other than contingency management. And we know patients with stimulant use disorder do very poorly. They're unable to adhere to their ART. They have adverse HIV outcomes, transmit HIV, etc. So some medications there to try for us as internists. Okay, this is the fun part. This is us talking about this new emerging drug class. So we're going to start with an audience response question. Which of the following is not an FDA-approved treatment for opioid use disorders? A, semaglutide, B, naltrexone, C, methadone, D, buprenorphine. I'm going to give you a few minutes to select an option. And I'm going to let Fatima, there we go. Okay, great. Ooh, so I need to make these questions harder next time. Okay, so the vast majority of you selected semaglutide. So let's learn a little bit more about this drug. Get us back on track. There, oops, sorry, there's our right answer. Great, guys. Okay, what are GLP-1 receptor agonists or GLP-1? This is a drug that is inspired by the endogenous GLP-1 that is produced and excreted in the intestine and pancreas after a meal and signals satiety or being full and reduces cravings and additional intake of foods. It has recently been discovered that there are genes that encode for GLP-1 widespread, including in the CNS, which likely explains this impact on satiety and some of these cravings for food and what is referred to as food noise, or thinking about and being preoccupied with food, your next meal, snacks, etc. GLP-1 RAs were designed to treat diabetes and obesity, and many of you probably have experience either personally or a family member on these, or prescribing them in your clinic for diabetes and obesity. They have been around for a long time, a lot longer than I even realized. I believe around 20 years. Again, not used for substance use disorder, but for diabetes and obesity, whether experimental or now more recently FDA approved. They enhance glucose-dependent insulin secretion and they slow gastric emptying, reducing postprandial glucagon and food intake. So again, designed initially to help with diabetes, metabolic syndrome, and now we're seeing that there are some CNS benefits that can be really exploited and used to assist in substance use disorder. So they are an emerging pharmacotherapeutic target for substance use disorder. And some of the relatively recent literature has shown that these agonist reduce alcohol, psychostimulant, opioid, and nicotine use, and other addiction-related outcomes in preclinical models. There are some clinical studies that support the safety and potential efficacy of GLP-1 RAs in addiction treatment. And there are many trials that are ongoing, underway now that I'm going to tell you about. But I just wanted to show the range of targets of the GLP-1. So you can see disseminated throughout the CNS, you can see these peripheral targets, pancreas, GI tract, really diffusely located throughout the body. And then on the right, I just wanted to remind you of this cycle of addiction, which starts with binge intoxication, a withdrawal and a negative effect that leads to craving, and then a preoccupation, anticipation. And that's really that green area is where it is thought that GLP-1 RAs are acting to reduce substance use in patients who are using them. GLP-1 RAs reduce alcohol-related responses. So this is a nice image that I found from a review article here showing the myriad ways that GLP-1 RAs are thought to reduce alcohol. They reduce the reward, the motivation, and the alcohol seeking, the memory of the alcohol-induced reward, relapse drinking, abstinence symptoms, and then overall alcohol drinking. So that is very encouraging. Again, a lot of this is very new data, but encouraging at the same time. What does the literature show in terms of efficacy? I looked up some systematic reviews of GLP-1 RAs. These are all, you can see this literature is all from like the last 1 to 2 years of clinical trials of GLP-1 RAs. There are 5 articles that met the criteria of assessing therapeutic effect on substance use disorder. 630 participants received either exenatide and dulaglutide. And you can see the N equals 3 and N equals 2 is the number of studies, not the number of participants. 3 of the 5 studies demonstrated a significant decrease in alcohol and nicotine use. And from the prior slide, this is probably not surprising, thinking of all the ways that these drugs can reduce alcohol use. And then in addition, 3 studies reported a reduction in weight, BMI, and A1C. And so one of the big takeaways for me in thinking about these for my patients is that many of my patients who drink heavy alcohol and nicotine use, I think could benefit from a little weight reduction, thinking of some cases, reduction in BMI, A1C. A lot of my patients who are in active use from opioids or stimulant use are actually on the small side already. And that is one of the questions that these studies have not answered for me is of my patients in active use, whether it's stimulants, whether it's another medication, who are not having good oral intake, who are already frail and have a low BMI. It's not really clear to me what the role for these medications are in that group. I looked up this scoping review of GLP-1 RAs in substance use disorder broadly. Again, a recent publication in the last year, 5 studies included in this review for tobacco, alcohol, and cocaine use disorders. The studies were varied, including the patient populations, the dose, the formulation of the GLP-1 RA, and the follow-up period. 3 studies did show a therapeutic benefit in terms of substance use outcomes, and 2 studies did not show efficacy when it came to substance use related benefits. So the conclusion, as is often the case, is that we need more research, again, specifically on the best patients, the dose, formulation, and durability of response, I think is where we really need more research. So another audience response question, thinking about this drug class, which of the following is a common side effect? Abdominal pain, hepatitis, rash, hypotension. Great. Oh man, you guys, I'm going to have to make these questions harder next time. So the vast majority got it right. It is abdominal pain. And I think one person put hepatitis. All of these can occur, but they are not the most common. The most common is abdominal pain, GI distress, nausea, constipation, just due to the effect of the GLP-1 RAs in the GI tract. Okay. So what are the current recommendations, which is I think why most of us are tuning into this topic. We're hearing a lot I am in the lay press and the media about people who started this drug class for diabetes or weight loss, and all of a sudden they no longer want a drink of alcohol, or they've stopped their tobacco use, which was a 40 pack year habit prior to using their GLP-1 RA. What you need to know is it is promising, but it is still just FDA approved, this drug class broadly for type 2 diabetes and obesity. There's a box warning for thyroid C cell tumors. It is contraindicated. This class is broadly contraindicated in those with thyroid cancer or MEN2. This is based on mouse models, but still contraindicated. There are some reports of suicidality that the FDA posted an investigation January 2024. I have not seen a closure to that investigation, but it is not a black box warning or a contraindication. The adverse reactions that are rare but to know about: kidney injury, retinopathy, the GI symptoms that I mentioned, pancreatitis, thyroid cancer, which we talked about, hypersensitivity, which is rare. Those are the big things for us to be watching about. One thing I did see in the pre talk questions that came in to IAS-USA was a question around ART and drug-drug interactions. And I did find a review article that I'll share in the chat, but the bottom line is there are some concerns that this drug class broadly may have an effect on the acidity of the gut, gut motility, that may affect ART efficacy, but these studies are still ongoing, and there's really no best practice at this time on dose adjustments, ART changes, et cetera, when using a GLP-1 RA at this time. And again, I'll share this review article in the chat. But for now, a lot of people are using these drugs already for diabetes, already for obesity in patients living with HIV. There is not a contraindication to using them in patients with HIV for these FDA-approved indications. And I think we'll hear more in coming months and years, hopefully. So with that, I believe that is all of my slides. And hopefully we have some great questions in the Q&A for discussion.
Thanks, Ellen, for a great overview. And Dr. Sag, I'm sure, will join me in asking some questions. But let me start out by saying, I mean, all of this is very important to the quality of life and the duration of survival for our patients. And yet, which part of the workforce do you think ought to really be delivering these services? Because as you well know, since you're one of the IDSA leaders, getting ID physicians to add this to their repertoire is a challenge. So the question is, in the outpatient setting, who should really be doing this? Is this the responsibility of ID physicians? And then I'm going to answer you the same question about inpatients. Should we be starting these discussions when patients happen to be inpatients? So can you summarize all that in 2 minutes?
Absolutely. I have been thinking a lot about this in a busy Ryan White funded clinic where a lot of our providers wear multiple hats. They may see patients 2 half days a week. And even when the X waiver went away, which was the requirement for additional training before treating opioid use disorder, specifically with buprenorphine, we thought that when that additional training requirement went away, we'd have a lot more HIV providers prescribing buprenorphine. I have not seen that. My colleagues have not seen that. So there's still some concern, anxiety around treating opioid use disorder. And you can imagine adding alcohol use, tobacco use, et cetera, to our toolkit is anxiety provoking for a lot of clinicians. What I tell my colleagues is just pick one thing. Maybe you're going to focus next year on tobacco use, and you're going to start talking more about varenicline, nicotine patches, and I think chipping away, adding more clinicians who are willing and able to treat one of these conditions. I do think the nurse practitioner model is very effective. If there are resources in our clinics to have an APP who is the substance use champion, that is on my wish list in my clinic. I think that is the most effective model because, as you can see, a lot of these are algorithms. They're not. We should all be comfortable with them, but many of us don't actually have the time to go in also and do the motivational interviewing for alcohol use disorder, the expert, tobacco use. And so having a dedicated champion like an APP whose job is to get to know the patient's use behaviors, counsel, provide motivational interview, frequent follow-up. Hey, we started a nicotine patch last month. We're bringing you back in January. We want to stay on this. We want to get you off the cigarette. So I do think that model is highly effective. And then in the inpatient setting, I have the benefit of having an addiction medicine consult service, but most hospitals do not. When I'm on the ID consult service, I do start talking about first their use behaviors as I'm getting to know them. And then as they progress through the hospitalization and they feel more comfortable with me, I then start talking about things like buprenorphine, things like harm reduction, sterile syringes. We talk about Hep C, screening, treatment, the whole syndemic that we're seeing of these additional infectious diseases with substance use gives me an opportunity to talk about the risk behaviors and how to address them, whether that is contingency management, whether that is referring them to a syringe service program. I don't live in a state where those are legal, but many of our participants today probably do. So I personally, as an ID doctor, think once you commit to that, and again, maybe you're not starting naltrexone in the hospital on your patients who came in with endocarditis, but starting the discussion, and maybe for the next year, you are going to commit to asking questions about how and where they're injecting, and you're going to start harm reduction counseling. And maybe that is your goal for the next year. And then after you feel comfortable with that, you're going to start adding, buprenorphine. You're going to start adding these other mirtazapine for stimulant use disorder. I do think thinking about this whole field as something that we have to own is intimidating. And I say that as someone who continues to be intimidated. Each year, the new guidelines come out from the Addiction Society, so I can relate a lot to the busy clinicians on the call, but taking one condition, one goal for this year and chipping away at substance use in your patient population, I think makes it much more feasible and sustainable for a busy clinician. That was
Well,
more
that's
than
so
two. That was more than 2 minutes, but
well, that's incremental. So let me ask you two questions. Then I'm going to let Dr. Sag pipe it. Yeah, for your nurse practitioner services, are those billable?
yes. So the model that we have used in our clinic successfully for women's health, doing a lot of the screening, treatment, et cetera, is what I'm trying to replicate. And again, it's an administrative ask, it's a cost ask, but a lot of these services, whether it is and hey, it's a lot of the women's health services too that Addiction Champion could do too, because these patients do need to be screened for STI often. And a lot of our APPs, if they have a DEA, can prescribe buprenorphine. Now, state requirements are different, so I don't want to speak in too broad of terms, but depending on your state, a lot of this work could be done by an APP who has her DEA, and they can and should be doing all the other things too, right? STI screening, Hep C screening, linkage to treatment. I do think, especially in rural states where we have a shortage of ID doctors, much less addiction doctors, if the work is going to happen, it's going to happen by family medicine docs, folks like us who are on the call, taking ownership. And I do think starting with one condition, maybe they're starting with tobacco use, then buprenorphine, but I do think that's the way to build capacity in a lot of our clinics.
All right. Well, I'll ask you one more question, then see what Mike says. One of the registrants, I think, just to summarize what I think is being said, is it's frustrating to send patients to a psychiatrist and then have them outsource the addiction to another clinic. So a lot of patients are lost to follow-up. I don't know whether there's any solution to that, but what's your approach to making sure that they don't have to go to too many different places, which probably none of us would tolerate reliably?
I've seen this too. Believe it or not, I sent a patient to psychiatry who was having active hallucinations and had a history of depression, and they sent the patient back saying, you actually need to see an addiction medicine provider before I will manage your mental health condition. I think that's just one more reason that we within our clinics need to have resources. Maybe we don't feel comfortable treating acute psychosis, but can we help stabilize and manage the underlying stimulant use disorder, in addition to the psychiatrist who has said, it sounds like, that they won't manage it. I think that's just one more reason that we're going to have to build capacity in our clinics, because you're exactly right. Once you start sending people to an addiction medicine doc, a psychiatrist, that's transportation, that's co-pays, that's out of network potentially, lots of barriers. So I think that's a reason. I mean, I hate to say it, but even mental health support that we need in our clinics to meet patients where they are, in addition to substance use disorder services. So it's a lot to ask, but starting small does make it more feasible.
Yeah, well, Mike, you have some
Yeah.
questions, because I think, it's wonderful to see this clinic that you started focusing on opportunistic infections and antiretroviral therapy. He's evolved so far as the epidemic has evolved.
Yeah, it's been 40 years. And I think a lot of folks are having the same experience. So a couple comments, Ellen. One of the participants said just remember to include PAs when we talk about APPs. And of course, that's what you mean. Sure. One of the questions about the obvious, semaglutide may work, but even for people with weight gain and hepatic steatosis, they're having trouble getting the drugs paid for. I don't think you're going to solve that on this call, but I think just to acknowledge that's an issue.
That's so important. And I think that's one of the reasons that we're doing this talk today. I think there's a lot of excitement. People have referred to this drug class as the next statin. Do we put it in the water? Can it cure everything from cardiovascular risk to tobacco use disorder? But, the devil's in the details. And just like our injectable long-acting ART, which it's been hard to implement and scale up. I imagine it's going to be hard to implement and scale up, even when we understand the best GLP-1 RA for substance use. I think it's going to require administrative burdens, prior authorizations, getting people on insurance. Yeah.
And then another comment appropriate is pharmacists can also help provide some of the services that you mentioned. So it really is a team effort, right?
I totally agree. And we definitely need pharmacists to help, because a lot of this, once patients are on these drugs, this drug class, and this pharmacist who commented may be doing this work, you can imagine a lot of the counseling, the screening for, monitoring weight, monitoring A1C, monitoring substance use behaviors. A lot of that, a pharmacist is very well trained and appropriate. And again, it's a protocol. So a lot of the clinicians on the call, whether you're a PA or your, pharmacist ID doc, a lot of us can do it. It's a matter of building it into our systems, like everything, right? Making time, space, getting a champion. That actually may be the hardest thing, getting a champion, and building systems that support these services.
Yep. And then the question, I guess, is should Ryan White clinics provide GLP therapy? I think what they're really saying is should it pay for it? And that's a budgetary issue. A lot of times Ryan White clinics will purchase insurance plans, but those insurance plans reject a lot of times the prescription. So it's a tough problem. Let me finish up. Well, I got about 2 minutes left, but I know this is critical. To me, a lot of substance use disorder, and especially stimulant use disorder, is about environment. And what I mean by that are the people who the folks hang around with. It's maybe episodic use, oftentimes in conjunction with sexual activity. How do you counsel patients about, if you're trying to change substance use, especially with stimulants, about how to change their network of friends?
That's a real hard one for 2 minutes, Dr. Sag. I think first, the fact that you acknowledge it is really important. I have seen clinicians and fellows get really frustrated when a patient is coming back again and again and is still using cocaine, even though they're in recovery on their opioid use disorder. But if they live with their sister and her husband and everybody smokes crack on the weekends, that's going to be really hard for them to quit smoking crack. That is there are so many patients who live with that family member who's in active use. So yeah, we're not going to solve that on the call. I do think it's important to acknowledge this, but when we ask patients to enter recovery and we counsel them and we encourage them to enter recovery, we're asking them to change the people, places, behaviors. We're asking them to change their life. It's not a matter of like, put down the cigarette, don't pick up the bottle. We're asking them to change their life. So I think acknowledging that's important. Housing, I think, is the biggest challenge to my patients who are in that environment. It's not just their friends, it's that they're living with people who are in active use. And that is the biggest challenge I see. So thinking creatively with your aid service organizations who help with housing, who help with low barrier apartments, that would, I think, be the most beneficial in my patient population. Changing your friends is also hard because a lot of these friends are actually support systems and cousins and maybe coworkers. So there's a lot of benefit to these relationships that may seem dangerous and damaging in terms of substance use. So it's very complicated. Does that
Yeah.
help?
Absolutely. So Henry, what I'm hearing here is that back 40 years ago when we were treating opportunistic infections, that feels a whole lot easier than treating an array of substance use disorders and having impact. But thank you, Ellen, for a wonderful presentation, and I think it's been extremely helpful.
Thank you so much.